to talk about the threat against public Medicare in Canada, which is at an all-time high. In Alberta, Premier Danielle Smith's new legislation, which was passed last week, brings in private health insurance and two-tier Medicare. Doug Ford is bringing in two-tier Medicare and private hospitals in Ontario after already pushing forward with long-term care privatization and private for-profit blood services. An array of organizations are also working to dismantle and privatize public health care in Canada and are campaigning in the media and on social media. At every turn, we're finding media stories, op-eds, reports, and initiatives spreading misinformation about privatization and pushing for more privatization. So today we have Ontario Health Coalition Executive Director Natalie Mera to give everyone an urgent briefing on the issue. Natalie has led the seminal research on private clinics and two-tier healthcare across the country, and this is for decades. She has researched pushing privatization and their methods. She's a leading expert on this topic and many others. And with that, I am going to hand it over to Natalie to get this briefing underway. Natalie?
Hi, everyone. Thank you so much for all of you joining so close to the holiday season. I think you all understand that our country would be something completely different had we not won public Medicare here. And you know, it's weird. I'm getting emotional because the attack on public Medicare right now is like something we've never seen before. It really is unprecedented. It's incredibly dangerous. And frankly, our side has not mounted the kind of fight that we need to mount in order to actually stop them. And part of the reason that I've called this meeting, and I'm so glad that you all joined, is because we have to fight back to stop them. The alternative is just inconceivable. So I'm going to run through what's actually happening. I'm going to start with the existential threat to public health care in this country, which is Danielle Smith, followed by Doug Ford and what he's doing, which is one step behind where Danielle Smith has gone now in Alberta, and then kind of move on to the array of organizations that are pushing privatization in Canada, where they're coming from, who's funding them, where they're connected to, and then what we need to do about it if we're going to actually fight to win. I'm going to try and get through this in time for a good question and answer period at the end, but I'm going to just kind of plow through the information to start with so that everyone understands where we're at. So I think we have to understand what we have before we can understand what we're losing, unless we stop them. And I think a lot of Canadians don't really realize exactly how public health care works and what it is that we have. I find that people kind of, are proud of our public health care. It's part of our national identity. We understand that it makes us different than the United States. And we can see on American TV shows and through our contacts and so on in the United States, what the kind of suffering that results from their private for-profit healthcare system. But I think that people don't really completely understand what public Medicare is. So I'm going to share my screen for just a moment. I'm going to go toggle back and forth. I know that's a little awkward, but it makes it a little easier to help people to understand. So I'm just going to go slideshow. I'm going to leave it in this view because it's a little easier to manage. So Canada began the process of creating public health care actually early in the 1900s. The fight for public health care followed on the heels of the fight for public hospital insurance, really. And the two have been kind of inextricably linked ever since. And so through the early part of the 1900s, as medical technology changed, as there was birthing in hospitals and antiseptic surgery and different types of drugs and technologies, the middle class and the upper middle class started to use hospitals. Prior to that, you hired in your doctor. There's all kinds of medicine sold to people in their homes, and the indigent and the poor used hospitals. The Spanish influenza really moved forward the push for public and charitable hospitals. Municipalities built hospitals, nuns and religious orders, charities as well, to help with the thousands upon thousands of people that got the Spanish flu in that pandemic. And then World War I and World War II resulted in just, so many thousands of veterans coming back injured, sick, and so on. Municipalities and charitable orders built more hospitals, and the federal government got involved at that point and started funding the building of local hospitals, forcing the provinces to do it essentially by offering money to communities and telling them that they would match communities' dollars or provinces' dollars, dollar per dollar. These 50-cent dollars became very popular across the country, and that built the hospital infrastructure. And so in the 1950s, we gained public hospital insurance, and then in the 1960s, public medical insurance. Justice Emmett Hall was actually a conservative judge appointed by Diefenbaker, and he was the chair of the National Commission on Public Health Care. And he said famously, the only thing more expensive than good health care is no health care. And that as a society, we are aware that the trauma of illness, the pain of surgery, the slow decline to death are burdens enough for the human being to bear without the added burden of medical or hospital bills penalizing the patient at the moment of vulnerability. The Canadian people determined, that they should band together to pay medical bills and hospital bills when they are well and income earning. Health services are a fundamental need, like education, which Canadians should meet collectively and pay through our taxes. When the Ontario Health Coalition was formed, we fought for the creation of the Canada Health Act. This was during an extra billing period in the late 1970s into the 1980s. Actually, as I understand it, was led by physicians in British Columbia who were sort of moving forward with extra billing of patients. And the Canada Health Act was brought in 1984, and it banned extra billing. So what it did was it established essentially a Bill of Rights for patients. It says that all Canadians have the right to access health care on equal terms and conditions without financial barrier. So, as Justice Emmett Hall was talking about, people suffering when they're elderly, when they're sick, when they're dying, they shouldn't face financial barriers to care at that point. That's the fundamental premise of public health care. And the idea that judge and janitor would share the same hospital ward so that they would have the same interest in a high quality public health care is embedded in the Canada Health Act and the idea of a universal public health care system for all. The Canada Health Act says that public health care belongs in the democratic realm, that it belongs in the public realm, that it should be publicly administered on a not-for-profit basis, that all provinces would have a public insurance system, and that system would cover all medically necessary hospital and physician services. And it bans extra billing and user fees. So like OHIP in Ontario or ASIP in Alberta or BC MSP or Quebec's RAMQ, all the provinces have a public insurance system, and the requirement is that every Canadian have equal access to healthcare based on our medical need and not how wealthy we are. And in fact, charging patients above OHIP or the equivalent in other provinces is expressly banned. You cannot charge user fees for healthcare services. You cannot extra bill patients under the law. There are a few other pieces of the law that people don't generally know about that protect public health care. In Ontario, we have a Commitment to the Future of Medicare Act, which was brought in 2004, and we are part of the reason that act was brought in, because we were fighting the very early days of private clinics and the extra billing. We also at the time had a health minister, George Smitherman, who actually cared about the issue, went up to Sault Ste. Marie, stood at the border as trucks were trying to come across. As I recall, it was with MRI scanners on flatbed trucks trying to sell MRIs to the worried wealthy, as they call it in Canada, medically unnecessary MRIs. And he kind of stood at the border and said, Yankee, go home, and we don't want this here, and kind of brought forward our laws. And under the Commitment to the Future of Medicare Act, it is illegal to charge a patient for an OHIP covered service, for an insured service. It's illegal to do that. So all those cataract surgery clinics that are currently doing that are actually breaking that law. They're supposed to be fined. The law brought in fines. It also allowed the minister to take away their OHIP billing number, so they couldn't bill OHIP anymore. And it also, obviously the minister can also cancel their license. All of those facilities are licensed facilities. And the fines are for corporations at a higher rate and individuals as well. So no person, no entity is allowed to charge someone for healthcare. In Ontario, physicians can also not opt out of the public health system. There's no opting out. In other provinces, there is some opting out allowed. In a number of provinces, there are kind of rules and regulations that limit that. What that means is, in the other provinces, if you're a physician that wants to charge a patient directly, and this was kind of the compromise struck in Saskatchewan at the very beginning, you can opt entirely out of public Medicare, but you can't bill the public system. So it's a barrier, right? So you would have to be able to make an entire client base, I guess you call it, patient base, out of people who can privately pay for healthcare in order to opt out. You wouldn't be able to bill both systems. And in a number of provinces, the government has the power to limit opting out and so on and so forth. That and the fact that a lot of doctors have great ethics and believe in public health care, combined with the fact that under the prime beneficiaries of public health care in this country are the doctors. Virtually all doctors are in the top 1 or 2% of income earners everywhere. And they're doing very well. That's just from their OHIP billings and none of the other, charges that they levy for medically unnecessary stuff. And so they're doing very well indeed by the public system. And these things have prevented them from, wholesale opting out of the public system. It's very, the chat is very distracting. If you don't mind, every chat pops up. Can you guys just leave it be, just unless there's a question or a salient comment? It's kind of hard to keep a train of thought here. Thank you. I totally did lose my train of thought. So opting out. So does everyone understand what I'm trying to say? In some provinces, physicians can opt out. Only a handful ever have. More in Quebec than elsewhere, partly because physicians are paid less in Quebec or have been historically, partly because of the influence of France and the French media in Quebec, but mostly across the country, just a handful of physicians have opted out. And obviously, even in Quebec, the vast majority of physicians are in the public health system. And so this is how we got public Medicare, and it's supposed to protect us. And it is probably the biggest, healthcare and education are the largest sort of social equalizers in the country. They're the largest transfers of income in terms of the tax and transfer system. They create equality of opportunity and support people to live to their human potential without financial catastrophe. Now, it's not perfect, and I think all of us know that. I mean, we fought as healthcare advocates for the expansion of public Medicare to cover drugs and long-term care and home care more fully, right? In Ontario, they're subsidized, but there are copays and limits to access to care and so on. And as they've moved more people out of hospitals and downsized public hospitals, every single service that they cut from public hospitals has been privatized, both in terms of who owns and operates it, but also in terms of who pays for it. And we've seen that erosion at work. But the principle of public health care, that it be a single payer system, is much less expensive. It's more equitable. It's humane. It works. And it's a thing that we are rightfully very proud of as Canadians. In Alberta, Danielle Smith, who is the Premier, and the UCP, the United Conservative Party, which was the sort of uniting of the far right, the sort of more extreme movement in Alberta with the former Conservative Party to pull politics kind of much more in the direction of the far right in the United States. They've brought in a new law. They passed it last week. It's called Bill 11. This law really blows up all of that. It fundamentally undermines public Medicare, not just in Alberta, but across Canada. I sent out a briefing note by email to all of you. I hope you got it. I see that it's gone into some people's spam, or maybe even many people's spam. If you have a look, you may find it in your spam. But it's a briefing note about the legislation. I'm just going to cover it really quickly. What it does is that it brings in private health insurance, private for-profit health insurance. It brings in private payment for needed healthcare services. And with it, so the user fees and all of the private payment for healthcare services, and it allows a two-tier Medicare. It brings in officially in legislation two-tier Medicare. I read through the act, and it's very clear when you read it that the act is about creating a market for private insurance companies in Alberta. It creates a category of employer, of workplace health insurance plans, so private health insurance in your workplace for current and former employees. It expressly allows physicians to both bill the public system and bill private health care. They can choose which procedures they want to do in one and which in the other. They can jump back and forth at any time. They can choose which of their patients they want to stream into private healthcare, private payment for healthcare, and which of their patients they will have pay publicly. So why would you do that? And they can do all that with just by sending a notice to the minister that they're going to be kind of a dual practice doctor opting in and opting out at the same time. And so that removes one of the biggest barriers to private healthcare. The second is they actually allow private for-profit health insurance. So they bring in officially private for-profit health insurance. And then they have these kind of funny clauses that say you can't extra bill or charge user fees for publicly insured healthcare. Well, kind of moot, since you can charge for the entire shebang. You can charge entirely for private healthcare. So, you're not charging an user fee or extra billing on top of paying for the knee surgery. You're paying for the knee surgery, or the doctor's visit, or whatever, range of services end up being entirely captured under this legislation. The doctor just has to notify the minister. Patients don't have a choice, similarly, whether or not they're streamed into private payment or the public payment system. The physician just has to notify the patient in writing. They have to tell them the price of the procedure. They have to tell them they have the right to go somewhere else and not pay. The patient then would have to go and try and find a doctor that would not charge them for that service. That's how the legislation is set up. So why would you do that? Well, you do it to make it easy and less risky to create a private health insurance market. Currently, doctors wouldn't want to do it because it's risky for them, right? You'd have to opt out entirely. In this case, you can opt out, you can jump back and forth at any time, you can bill one and bill the other. And so the public system is the safety net for those people who are then acting as your operatives to set up a market for the private health insurance industry. That industry will then create products which they will sell to workplaces and so on and so forth. Where there is workplace private health insurance, when you lose your job, you lose your health insurance, right? And that's what happens to people and all of the attendant problems that go with that. Albertans would then be paying for public health system and for private health insurance. Unions would be pressed into bargaining. They would be pressured by their members into bargaining for private health insurance like they do in the United States. Those demands would take the place of demands for improved wages and working conditions, pensions, and other benefits. The elderly, the poor, those people who are chronically ill, people living in rural and remote communities where there isn't, and northern communities, smaller towns where there isn't a big market of people who are wealthy enough to pay for private health insurance, or companies that are large enough to have private health insurance, people who can't get insured because of their medical condition or their age. All of those people will lose out in this system, and healthcare resources will be shunted towards the largest urban centers, the wealthy, the young, the easy to insure, people who can pay for private health insurance or pay out of pocket for private health care, away from everyone else. So I think you can see why I'm saying this blows up single tier Medicare. It's the end of single tier Medicare as a national project, as a national achievement. And part of the reason why I'm a little emotional is that I haven't been able to sleep for a couple of nights. I'm worrying about our country and what it is we're going to do here, not just for this, but for other issues as well. It is the most serious threat we've seen since the inception of public Medicare in this country. And we have to do everything we can do to fight back. Okay, so I've briefed you on Alberta now. I think I've covered completely the main parts of the bill, but I haven't covered all the consequences. Obviously, there are other consequences as well. Under the trade agreements, we believe that this is the case, and we need a legal opinion, but the way it was that public health insurance, the public healthcare system in Canada, was carved out because it was public. Once it becomes privatized, we believe that that protection no longer stands in the trade agreements. And so the trade agreements require that American businesses, for example, the US trade agreement, the US businesses have the same rights to market entry and all of those things as businesses in Canada. And so once you bring in private for profit health insurance in Alberta, the fear is that it puts at risk public health insurance across the country. The other thing is that, of course, the insurance companies are not going to stop at the Alberta border. They'll have created products in a market in Alberta. They'll be pushing for it elsewhere. The very right-wing governments in our country, Scott Moe in Saskatchewan, Doug Ford, despite his very popularist, gee shucks guy kind of PR, is an extremely right-wing premier and has brought in extremely right-wing legislation ever since he took office. Other premiers across the country, also a problem. And so the push will be on by a much emboldened for-profit, private insurance industry to ratchet open the system everywhere else. But in addition, like the private clinics have done in across the country since the inception really of the private clinics, they established the facts on the ground. That was their strategy. It was to go ahead and extra bill patients and charge user fees and challenge governments to come after them for doing it. Paying fines would just be part of the cost of business, like the for-profit long-term care industry has done. If governments actually do ever enforce the laws and standards against them, well, they'll pay the fine and move on. But the fact is that governments don't do it, and they haven't done it. And even despite enormous pressure from us to crack down, they have cracked down at times and stopped the extra billing and user fees when we have fought hard for that in the private clinics. And there's only really a few across the country at this point, but more all the time. But the governments don't fine them. They don't take away their licenses. They don't use the full force of the laws that they have to enforce our public Medicare laws against them, just like in long-term care. And in fact, in long-term care, what we learned was that the for-profit industry lobbies for deregulation. So when regulations exist, like every long-term care home should be inspected, should be subjected to a surprise inspection every year, they lobby to remove that. Then we have to fight to get that back in. Then they lobby to remove it again. Then they lobby to remove the enforcement. And where there are things like minimum staffing standards, the only one that exists in long-term care is one RN 24/7 per home, which is ridiculously low as it is. That's a 400-bed home or a 40-bed home. They lobby to get rid of that. That's too much for them. They want to replace the RNs with lesser paid and lesser trained staff. That is what the for-profit industry does. There's a reason why The meta-analyses, the big studies of for-profit healthcare show higher death rates in for-profit hospitals and for-profit clinics. It's because they cut corners, they replace higher paid staff with lower paid staff. It's because in the hemodialysis clinics, they push the blood through faster to get the patients in and out faster, so because it makes them more money. It's those sorts of things. And there's a reason why, we have to fight the privatization of the ownership of our healthcare, and then also the privatization of who pays, because the private for-profit interests want to build the public health system and charge patients on top. That has been the fight since the beginning of public Medicare in Canada. It was banned in the Canada Health Act. It's been banned in our provincial legislation, and the kind of existential fight for to stop that is on. So in Alberta, bringing in two-tier Medicare means that the private health insurance industry will very likely start to sell products across the country. A number of years ago, it wasn't that long, pre-pandemic, in British Columbia, BCAA tried to sell private health insurance for medically needed services. That's not allowed, right? That's not allowed. The BC Health Coalition launched a campaign, and within, I think it was 48 hours, anyways, just a couple of days, they had enough people making complaints, threatening boycotts, raising, hell about this, that BCAA stopped it. I mean, they were able to stop it. But imagine now if we have 20, 30, companies selling private health insurance in Alberta, and they start to sell it online. Now that's way easier than it was pre-pandemic, online across the country. And then we're begging the Ford government to stop it, like they've stopped anything so far in terms of two-tier healthcare. They have not, right? It's going to work its way in across the country. That's not sort of fear-mongering. That is the reality that we now face. The point is that this fight is everyone's fight. If we don't fight now to protect public health care in Canada, we will lose public health care in Canada, not just Alberta, and it's bad enough for Albertans, but across the country. In Ontario, the Doug Ford government has not moved quite as far as Danielle Smith. Danielle Smith in Alberta, I should say, she's the premier. She preceded this act by bringing in legislation to allow private hospitals. In Ontario, the Ford government is moving forward, trying their hardest to privatize the hospitals. So in early December 7th, they announced another $125 million to privatize orthopedic surgeries in the province. That follows on the heels of an announcement in the summer of $155 million to open 57 new private clinics. Some of those are set up as hospitals, essentially day hospitals, like whole hospitals with operating theaters, MRI suites, the whole 9 yards. As many services as they think are profitable that they're going to get in there under a friendly government to them, like the Ford government. The vast majority of the private clinics in Ontario are for-profit. And as you know, we have done repeated rounds of calling all the clinics and catching them extra bill patients and charge user fees for patients. We've collected complaints repeatedly from patients. We've brought this information to the provincial minister of health. She has done nothing about it. We've raised questions repeatedly in the legislature about it. She has never answered the question. She keeps talking about it as big investments, as reducing wait times, and so on and so forth. For those of you who haven't followed closely, every surgery in the private clinics, the expanded cataract surgeries, costs more. In fact, we're paying $500 per surgery in public hospitals, $600 or more in the private clinics, $1,200 in the one private hospital that still exists in Ontario that does cataract surgeries. By the way, private hospitals are banned in this province and have been since the inception of OHIP. And for good reason. So the way they're getting around it is by bringing in private clinics instead. And so they're expanding them. They tried in the last 3 years to double the funding to the private clinics. They were not able to succeed. They repeatedly announced that they were going to expand the private clinics, and they repeatedly gave timelines for them. We have managed to slow them down. Every step of the way they've been subject to freedom of information challenges to get the information on costs. They've been questioned closely by the media. That's our work. That's all of our work. Pushing, educating people, getting them to understand the issues. Every step of the way, they've faced stiff public opposition. They know the majority of Ontarians oppose privatization of our healthcare. That's why they never want to talk about it that way. They called the private clinics something like community independent community facility. I can't even remember the it's a long acronym, but they won't call them even private clinics. They don't want to use that language. And despite the fact that, as I say, they tried to double their funding, they were not able to achieve that. They increased their funding by 30% at this point. And then the two announcements of another essentially $300 million, $275 million, which is a lot of money, will attempt to more than double their funding over the next 2 years. I don't think they're going to get there, because we're going to fight like hell, because we're going to do everything humanly possible to stop them. But let's not be naive. They have announced 57 new private clinics. That's the first expansion in the number of private clinics in an entire generation, like since the inception of the legislation covering private clinics. And so we really do have a very, very serious problem here. And if we lose the ownership and control of the vital hospital services in Ontario, we will lose single-tier public Medicare. There is no question in my mind, and we've followed this, as you know, very closely for 30 years. So in addition to the privatization of the hospitals, I shouldn't fail to mention they are midstream in privatizing the ownership of the next generation of long-term care homes and beds to the worst companies, to the same for-profit chains that were responsible for the horrific death rates in the pandemic. They have allowed privatization of our voluntary blood donation system. They've brought in for-profit paid plasma, Grifols, a giant pharmaceutical company is now opening clinics across Ontario where people, and they're advertising for people to go and make money by selling their blood. You know, there's a line. We don't sell organs. We don't commodify human organs in our society. It is way over the line to do that, but they have brought in privatized blood services, and we have to fight that. They are privatizing parts of primary care. They're also expanding the good part of primary care, of community health centers, some nonprofit family health teams, and so on. But they've also allowed Maple in, who are charging people for online access to primary care. They've allowed for-profit nurse practitioner clinics that are charging people for access to primary care. There's no reason for that whatsoever. We've had publicly funded nurse practitioner clinics since 2010. And only under this government have they allowed private charging of patients for those services. So we have a fight in primary care as well. And then there's a whole host of other things, you know, functions of public health and so on and so forth that they've privatized in Ontario. Anyway, we have to draw a line, and the line has to be that we stop the transfer of the ownership and control of our hospitals. For those of you from smaller towns, rural towns, and the north, I can tell you definitively that the private clinics are not locating in Northern Ontario. They're not locating in smaller towns. And in fact, the Ford government has pushed the majority now of Ontario's hospitals into deficit, telling them that they have to make cuts, right? They have to make cuts in order to eliminate their deficits. Forced smaller community hospitals into positions where emergency departments and urgent care centers, even entire hospitals, are under threat of closure or are closing down. And while the majority of Ontario's public hospitals are facing these deficits, they're shunting another $300 million over to private for-profit clinics to take over public hospital services. This is not anything to do with wait times. The vast majority of Ontario's public hospitals have operating rooms in them that are closed all the time because they're used as storage because they don't have the funding to run them. Of every large hospital might have one operating room operating in the evenings and on weekends. The largest might have two. The rest of them are closed. They're only open from like 7 a.m. or 8 a.m. till 3 or 4 or 5 p.m. and then they're closed. They're closed the majority of the time. Why? Because they don't have the funding to staff them and run them. At the same time as the government is shunting off all of these resources to private for-profit clinics to build new operating rooms and MRI suites and so on and so forth with our money to make profit from. They exist in our local public hospitals. Our local public hospitals are more equitably distributed across the province in the north and in rural communities. Not as equitably as we would like. We'd like more, and we would have liked to stop the closure of some of them that have been closed, but nonetheless, far more equitably than the private clinics. This is a fight for rural Ontario. The Conservative base in rural Ontario needs to understand that this is a shift of resources away from their local public hospitals that we have all spent a century building in order to shift funding and resources to private for-profit clinics and two-tier healthcare that we all oppose. We have not gotten out that message. We have to get out that message. This is a fundamental threat to single-tier public health care. Doug Ford swore you'd never pay with your credit card, only your OHIP card. People going to the private cataract surgery clinics are being billed out of pocket. They're being charged cash. They're being charged on their credit card, and they're being charged on their OHIP card. The cost for cataract surgeries has gone through the roof. They've taken funding and resources away from our public hospitals when there's all kinds of capacity there to be used if we want it. Okay, so that fight has to happen, and it has to ramp up. We can't be disheartened by, who won what election or whether or not we think he's going to stop. In fact, at this point, the forces that are on our side who are disheartened, who are saying nothing changes what's happening and so on, are as much a threat to what we're doing as the side that's trying to privatize. We cannot allow a lowering of our expectations. We cannot allow hopelessness or fear or the thought that we can't fight back commensurate to the threat to get in the way of just building a fight back that is like nothing they have ever seen. As we do more, you'll see things grow, the options grow, the possibilities grow, and of course we can stop them. I'm going to move on to now the last bit that I want to tell you about. The forces arrayed against public health care in Canada are obviously feeling very empowered these days. You may have heard of some of them. I'm going to just share my screen for a minute and just show you a few. Let me just see if I can get here we are. I'm just going to get this up, and I'm just going to go to a few different media things. You'll see that the Fraser Institute, for example, this is from October, this is CTV, released a new study, imbalance between the high-cost Canadian health system, this is their language, and the actual care Canadians get in return. Their solution, of course, roll down to the bottom, not to improve public health care, but allow it for private providers would provide a helpful solution, right? The Montreal Economic Institute came out with a bunch of reports in the fall about underservicing patients in emergency departments. Their solution, nurse practitioner clinics, those are private, giving pharmacists more scope. Oh, that's at Shoppers and private for-profit pharmacies. Creating private mini hospitals for non-life-threatening cases. It's all privatization, right? Create the crisis, privatize, or talk about the crisis, and your solutions, quote unquote, are all privatization. That was quoted all across, the country in media. Second Street, this is an organization that annually now in Canada puts out the number of people who've died on waiting lists while waiting for healthcare. However, you have to note that the people who've died, and I'm not being glib about that at all, could have died from any reason. I could be on a wait list for an MRI for something that is not life-threatening at all and get hit by a bus as I cross the street, and I count as a death in their report on while I'm on a wait list. Anyone who dies on a wait list for any reason, there's no causal relationship between dying and being on the wait list for healthcare. Those reports aren't even worth the paper they're written on, and yet they are getting headlines across the country for making it sound like the Canadian public health system is killing people on wait times. The National Post, their column, Alberta's healthcare reform, a small step without much difference. Come on, it hasn't gone far enough towards completely privatizing public health care. I'm showing you this just so you can see. There's an array of forces across Canada that are pushing privatization. A few little facts that I think would be useful for you about a few of these organizations. I'm going to just share my screen again, and I'm bringing up fact sheet on 2nd Street. Okay, well, let's start with 2nd Street. So this is the one that's coming out with these annual reports about the number of people who've died on wait lists that have nothing to do with whether or not they're on wait lists, as to whether or not they die. So 2nd Street's founder and CEO came from the Canadian Taxpayers Federation, which has always advocated for two-tier healthcare. He previously worked in Virginia in the United States as the National Education Director for the Leadership Institute, whose mandate is to train conservatives in the United States. The vast majority of his team also came from the Canadian Taxpayers Federation. One board member, Walter Robertson, is a former director at Purdue Pharmaceuticals and VP at Innovative Medicines Canada, which is a lobby group for the pharmaceutical industry. Also previously worked at the Canadian Taxpayers Federation. Other previous board members include Stephen Harper's former press secretary. So lots of connections to the Canadian Taxpayers Federation. The Atlas Network, I think some of you would have heard of this. It's a US-based organization with extensive ties to the extreme right-wing push in the United States and around the world. And the Koch brothers, which are, the two brothers that funded the Tea Party in the United States and this extreme right-wing push. They have funded 2nd Street, the Donner Canadian Foundation, which is, historically funded right-wing causes. I wanted to point them out because of their connections to the United States, which I think people should really know about and understand. I'm going to share another fact sheet very quickly on the Fraser Institute. The Fraser Institute has come out with repeated reports calling for privatization in various different ways, and sort of trying to talk down the public health system in Canada, sort of pose it as an outlier, as doing poorly compared to the rest of the world and all of those things, in order to, in my view, in order to sort of reduce Canadian confidence in public health care and soften up the public for privatization. So, of course, they include people who are tied to private healthcare industry. Sean Francis on their board is the chair and CEO of MedCan, a private for-profit health clinic that sells executive health care for thousands of dollars. They got funding at some point from the Koch brothers. We don't have total information about where they get their funding. They also receive regular donations from a Canadian subsidiary of the Koch brothers. I'm just going to continue through here a little bit. Dr. Brett Belchetz, I'm not quite sure how to pronounce his name, founded Maple, which is the virtual care company. It's the online access to doctors. They charge patients for access to doctors. Loblaw companies, through it wholly owns Shoppers Drug Mart. They've invested millions in Maple in order to, and Maple sells like for-profit access to doctors online. Michael Walker came from Canaccord Capital, an investment firm, another investment firm that backs Southbridge, a for-profit long-term care chain, and so on and so forth. I mean, there's all kinds of different connections, and so on. So these are the forces. It's a plan, right? They're funded. It's a plan. It's a coordinated campaign. In addition to what they're doing, the C.D. Howe Institute has been pushing privatization. The Canadian Constitution Foundation has funded the legal challenges in British Columbia that have attempted and failed to bring down the laws that protect single-tier public Medicare at every level of the courts. I'm happy to say they lost in British Columbia. Excellent work by the BC Health Coalition intervening in that. Dr. Brian Day, who is the owner of one of the largest for-profit surgical clinics in British Columbia and who was behind the legal challenges and also many of the campaigns in Canada to dismantle single-tier public Medicare. He's been doing rounds of the media. Often the media don't tell the public that his clinic was found violating our Medicare laws and charging patients thousands of dollars in access to services, that he brought the court challenges to bring down public Medicare in British Columbia and failed. The courts ruled against him at every level. But nonetheless, he's out there. And of course, things like the National Post with that kind of op-ed and other articles. So the forces against public health care are arrayed against us. And some of the things that they're telling people are completely untrue. And so I'm going to run through very quickly some of those things for you. We'll be getting them out in a much more systematic way, actually starting this week, very quickly, and then ramping up through the month and through the new year. But I'm just going to share my screen now and go back to my slideshow. Where did it go? Oh, here it is. Okay. So let's just get a few facts straight here so we can deal with some of the misinformation. Okay, let me see if I can. Will it go down? Okay, so this is their problem. All of the polling shows that the majority of Canadians support public Medicare, and the majority of Canadians want it to be nonprofit. That's their barrier, and they have to try and overcome it. They laid out their plans very clearly in 2005, and I put a link to a much more thorough article about this Save Medicare Summit, which was really a summit to dismantle public Medicare held by Brian Day in 2005. At that, Preston Manning, whom you may or may not know, he was the founder of the Reform Party and the attempt to push the Conservatives further to the right in Canada, present their ideas as a compromise. This was his advice. Canadians love compromise. Redefine two-tier Medicare as between the status quo and the US system. Make the extreme seem moderate. He said, make those proponents of single-tier public health care seem extreme. At the time, he said, start where there's vulnerability, such as Quebec. If he was talking now, he'd be talking about Alberta. And once the battle over language has been won, Manning said, it will be politically easier to follow the substantive prescription. Sorry, there's some typos in this. Completely dismantle national Medicare, have the federal government hand tax power over to the provinces, and let them handle Medicare as they please. Of course, he came from Alberta, and that was to privatize it. So first, let's clarify the facts about U.S. healthcare. In the United States, they're now spending just about double what we pay for healthcare in Canada, but they don't get it, despite all of that money. U.S. for-profit hospitals charge exorbitant prices. Businesses face high insurance costs for employees, and on top of that, employees pay co-payments every paycheck. Plus, they have to pay deductible before their coverage kicks in, if they're covered. Insurance companies make profits by denying coverage. And you may remember from the shooting of the U.S. health executive how furious Americans were at that company for having such a high rate of denial of coverage. Medical costs are the top reason for bankruptcy in the United States, and 56 million Americans struggle with medical debt. In the United States, there is no question that healthcare is an economic issue. It is absolutely an economic issue. Here, dangerously, our governments are talking about the economy as if it's ports and pipelines, but don't consider the public sector, like healthcare, to be an economic issue. losing healthcare, let me tell you, is absolutely an economic issue. It's the top issue for families in the United States. Alana, do you want to tell folks about the cost, the real world cost that we found out about in the United States? This is Alana Kong, our campaigns and research director.
Yeah, hi everyone. Thanks for being here. So yes, in the States, they have different ranges of like private health insurance plans, different categories according to how much premium you pay versus the deductible. And in the most popular category, it was reported in 2023 that the average deductible was $4,890. Um, and that's just the deductible. It doesn't include the monthly premium, or the copayment either. And if you're employed, your employer may cover the premium, but again, you still have to pay thousands of dollars out of pocket, not only for the deductible and the copayment. And if you're using like a healthcare provider who isn't in the health insurance network, they don't consider them to be in the network, then you also have to pay more. And so if we look at Michigan, which is just across the border from us, there you can actually just pull up how much the health insurance plans cost on the government website. They have like tons and tons of plans, and the plan with the lowest premium is still going to cost people $4,700 per year. The deductible is $10,600. And the maximum out-of-pocket payment is also $10,600. This doesn't even include dental care. And if we go to the plan with some of the higher premiums, it's $9,910 per year. The deductible is less, quote unquote less, but it's still $2,000 per year. And the maximum out-of-pocket payment is $8,200. And again, this plan still doesn't include dental. So again, Michigan is just across the border from us, and they're paying thousands of dollars per year. And this is just like per person. Like imagine paying this for a whole household.
Thank you very much, Alana. So we met a woman. Did you tell them about the woman from the St. Lawrence Market?
Oh yeah, so I think it was last year. We were doing some fundraising at the St. Lawrence Market, which is in downtown Toronto. We were selling garlic for our annual fundraiser and like Rosie the River to lunch pails and all that. And this woman who was on vacation, she came up to us and she shared that at the company she works for, not only do they have to, of course, pay for the premium for the insurance plan, but the employees themselves are paying like the deductible, again, the co-payment, and I think in total it's like $10,000 they're paying. And so they actually, like it's costing them way more money than it would have under like public health care, is what she told us.
So she was from Chicago, and she had a pre-existing condition, and she had to pay a $10,000 deductible before any of the insurance even started. So at the beginning of every year, she'd have to pay for the first $10,000 of her health care. Her employer and she both paid, I think it was $1,000 a month for the health plan that they had at their company. And she was talking about how the company had talked about relocating to Canada because the employer costs were so much lower because we don't have private health care. Okay, so United States, almost double our costs, yet they don't get the coverage we have. And yes, they do have wait times. They don't track wait times because they don't have a system of healthcare, right? So there's no official central tracking of wait times, but we were able to find lots of stories online from doctors complaining about wait times for their patients. So emergency physicians talking about patients waiting for hours or days for a hospital bed. Sound familiar? For rural hospitals being closed and rural services being closed. Residents spending 6 months looking for a family doctor and being put on indefinite wait lists. So the claim that the U.S. does not have wait lists for care, it's just not factual at all. The second claim, and you saw that in that first Fraser Institute story that I showed you from CTV, is that Canadians pay a lot for their health care. In fact, it's frequently claimed on social media these days, and this sort of stems from the right-wing think tanks that are putting out this misinformation, that Canadians pay the highest taxes of anywhere. We do not at all. In fact, we are in the 26th lowest tax wedge among the 38 OECD member countries. The tax wedge is a calculation of both employee and employer costs. And just looking at employee taxes, the average single Canadian worker's taxes are almost dead in the middle of the entire OECD. So that's all of the wealthy nations on earth. And this tax thing is really misleading people anyway. It's disingenuous because, in fact, the tax and transfer system mitigates the income inequality dished out by the private marketplace. If you were born after 1980, you've been born into a country in which wages have been becoming much more inequitable. And I just put this chart up very quickly so you could see that the highest, this is in real dollar terms, the highest income earners have gained about $100,000 in income over the last generation. The middle income earners, which would be the sort of blue line here, the upper middle income, the green line here, the upper middle has gained, what is that, about 15,000, 14,000. The middle, lower mid has gained 5,000. The lower income households have lost, second to lowest have lost $8,000 a year, and the very lowest, who had almost nothing to lose in the first place, have also lost. So our income inequality has been getting much greater. What that means is that executives and owners and the highest income earning class have taken all of the economic growth of the last generation for themselves and have not passed it on in higher wages to everyone else. But the tax system mitigates that income inequality. And so the blue line here shows what it looks like. The lowest decile is the lowest 10%, and the highest decile is the highest 10%. And market income, that's before tax, and then after tax income is in orange. And you can see that it's really only when you get into the highest income categories that you're losing income after taxes. Everyone else is gaining income after taxes. So the tax system actually serves as a bit of an equality dampener on this raging income inequality that now in Canada has grown to an unprecedented gap. Canada does not spend more than others. We're not a high spending country on healthcare. We rank consistently in the low middle of other wealthy nations on healthcare spending. This is us here. Above us, Germany, Norway, Netherlands, Austria, France, Switzerland, Luxembourg, Sweden, Denmark, Belgium, Ireland, Australia, and then here we are, Canada, in the low middle of comparable countries. In countries like Germany and France, and some of those others that you note are on the higher end, these are countries cited by people like Danielle Smith and the right-wing think tanks pushing privatization. They have a private healthcare system and a public health system, and despite the claims of the privatization forces, the evidence is irrefutable. They pay more for healthcare than we do. It costs more to privatize. In Germany, for example, not only does it cost more, but there are indeed wait times. Again, like the United States, they don't actually track wait times like we do. But studies comparing wealthier patients who buy supplemental private insurance with the rest of the population shows indeed that there are wait times for the general population. And so we found, for example, an eye exam, the wait was over a month, and there was a longer wait, more than 70 days, for a pulmonary function test. Those are just some examples. The French health system actually also costs more than Canada's. They have two-tier healthcare, and people have to pay out of pocket or buy private health insurance. And the problem there is that they also pay their healthcare workers, used to be just about half what we paid. So higher cost despite the much lower pay for healthcare workers, which obviously is a big problem. Australia, I mean, you can find this all over the internet. If you're looking for studies, it is well studied. It is not cheaper. It does have wait lists, and the private system has caused all kinds of problems in the Australian healthcare system. I'm not going to go on too long about this evidence because we'll send it out to you in writing and you'll have it. We'll create little videos and all of those things with it so people will have it. But just to say that the claims of the pro-privatization forces are false. You know, they are not using evidence. They're manipulating the truth in order to push a narrative to push Canadians towards privatizing our public health care. In terms of fighting back, you know, every time we've fought privatization, we've won. It is a difficult time, without question. Mostly, if this kind of thing was happening under previous Liberal governments, they would have brought in a royal commission, and you know we would have had a paper that comes out that recommends improving and protecting single-tier public Medicare. Mark Carney is now on a track in which he is focused on obviously the external threat from the United States and doesn't really talk very much about the values of equity and compassion, of social inclusion, and all of those things that public services entail. We need to push him to do that and to understand it. So far, they have not spoken out against Alberta and Danielle Smith, and that's a problem because, of course, they want other things from Danielle Smith. We are going to have to act as countervailing pressure to Danielle Smith and her forces in Alberta on the Carney government. The Carney government, unlike the Ford government, does respond more to pressure. So let's not let Pierre Poilievre and Danielle Smith be the only foci of pressure on the Carney government. They have to hear from us, and they have to hear from us en masse that we expect them to stop Alberta and to stand up and protect single-tier public Medicare and to stop Ford in Ontario as well. In Ontario, we're going to have to pair what Ford is doing with what Alberta is doing and build the fight back against them both. And they are inextricably related. You privatize the ownership of healthcare, you lose the public single-tier system. In the winter, we're going to have our assembly January 24th and 25th. That's a weekend. We're going to bring the next mass leafleting campaign. The goal is to reach every healthcare worker in the province of every classification, all the optometrists, all the local doctors, all the nurses, support workers, health professionals, and so on. Work with the unions, work with local health coalitions, work with volunteers, work with the community health centers, the seniors organizations, the teachers, the nonprofit groups, all of the people who support public health care in this province. Reach every healthcare worker to explain to them why they need to support public health care and help stop privatization, why it affects their work and the ethics under which they work, their workloads and the real life experiences of their patients, why they need to advocate for their patients on a system basis. We also will have a leaflet for the general public, raising the alarm about the threat to public health care and calling on the public to take action. We'll bring those leaflets to the assembly. It's the cheapest way for us to distribute them across the province. So everyone who drives in, we can send them back out to all of the various parts of Ontario. I encourage you to come to the assembly. It's where we're going to hone this strategy. The proposed strategy would be that we hold 10 1,000 person protests. So a 10,000 person roll to stop the Ford government from privatizing healthcare. That we choose 10 locations across Ontario throughout the province, including those areas where there is media, where it will cause maximum pressure for the Conservative government, where we have capacity to do so, and pull out large, not 30 people standing outside an MPP's office, but 1,000 people demanding that they stop privatizing our public health care in 10 places. We roll that out through March and April. In May, we would hold Get on the Rails protest, a whistle stop protest where we would hold rallies on the train station platforms, starting in Windsor and Ottawa and Sudbury and Niagara Falls. Rally, we would book entire train cars or entire trains. We're figuring it out right now. People would get on the train to come to Queen's Park. So rally in Windsor, get on the train, go to London, rally in London, get on the train. We book cars. We'll work with all of our affiliates to do that. We'll get as many trains as we can, go trains, et cetera, come from all of the different directions. Giant march on the legislature in May to demand that they stop the privatization of our public health care. All of this underlaid with enormous public pressure, social media, demands that our local MPPs stop it, public messaging so people understand it is a takeaway from our local public hospitals, not an add-on addressing a wait list in Ontario, demands that our federal government stop the privatization, perhaps protests outside every MP's office across the country if we can build it with the forces across Canada, and all of the pressure that we can mount. Currently, we have a petition. Alana or one of the staff will put the link, maybe Genevieve, in the chat for that. Please sign that petition. There are 8,000 people who signed it online. You know, we can do far better than that. Like, I'm just sort of disappointed by that. Please go in there and sign that petition. It's 5 minutes maximum of your life. It matters that we have huge numbers at this point for that. And then everything else that we can do to try and build the opposition, to educate the public, to organize the public, to build visible resistance so people know that there's a fight, they know how they can join that fight, and so that they have effective things to do when they join that fight. Okay, so I'm done. Sorry for the long briefing. I'll open it up now to questions and answers. Alana is watching the Facebook, right? The Facebook live stream. So if you have questions on the Facebook live stream, can you put them in the chat, in the comments? For people on the Zoom, you can raise your hands if you have a question or a comment. Please make sure we're trying to share space here, or a suggestion, or you can put them in the chat. And Genevieve is watching the chat. And so let's open up for questions, and then I'll just wrap up in about 20 minutes or so. Okay, Alana and Genevieve, go ahead and speak up. Are there questions and comments? Don't be shy. I know that people have some. There we go. Peter first, Peter, and then Carrie. Go ahead, Peter.
Yeah, hi, Peter from London, Ontario. Great presentation, Natalie. I notice we have friends out there that are doing also Zooms regarding the subject. Are you endorsing like the Canadian Doctors for Medicare? They have one tonight. Is the messaging all similar? And, you know, is it valued to spread the word that they're having Zooms as well? Or what's our primary focus, I guess?
Yeah, I mean, I think it'll be great. I did send a briefing note because I wrote the analysis of the legislation and others hadn't had time to do it yet. I sent that internally to the Canadian Doctors for Medicare and also across the country to the other health coalitions and so on. I also sent a note about language. My concern is that a lot of the language being used by kind of academic forces and so on focuses on dual practice in Alberta. That's the doctors being able to charge public health care and not. Dual practice sounds innocuous. It doesn't sound very threatening. But also they're mistaking the means and the ends here. The allowing doctors to both bill the public health system and charge patients directly or bill private health insurance is two-tier healthcare. And the reason why they're letting them jump back and forth and do both is so that the public system provides a safety net to develop the private health insurance system. It takes away the risk of having to jump entirely out to do it. That's why they did that. So the language has been this kind of, oh God, there's a lot of headlines that say public and private, or hybrid model or dual practice and all of this stuff. I'm mindful of that 2005 conference that Brian Day pulled together, in which they talked about changing the language to make the extreme sound moderate. Alberta's Danielle Smith and the UCP have brought in two-tier healthcare. They've brought in private health insurance for the first time since the inception of Public Medicare in Canada. Without question, it violates the Canada Health Act. It blows up equal access to healthcare for all. It blows up single tier Medicare in Canada, public Medicare, as a national achievement. I find the language very worrisome. I did lobby on that. I don't know what the results of that will be. We'll see. But so I'm using the language that I believe is accurate, that reflects what's in the actual legislation, and not what reflects, what has been said in the media, which I don't think is really captured accurately or clearly enough for Canadians. What is actually happening here? Sorry, I'm losing my voice. Okay, and so the next step, for us, the next step is get those petitions signed, like get the numbers of that petition up. We only have till January 17th. We should be at 100,000. We should be at more than that. I'm kind of shocked that it's not really going very far. I think the issue is we have a lot of paper petitions that people have signed. People need to do both because they have different wording because of the requirements for doing online petitions. In fact, I think it was maybe a mistake to do an online one. And because you have to sign the petition online, then they send you an email and you have to confirm. It's a two-step process. So I feel like that's a bit of a barrier for people doing it. But nonetheless, come on, compared to private healthcare, not that much of a barrier. Let's do what we can to get those numbers up on those petitions right now. We need to build for the assembly, and then we need to roll out the plan. Right now, we're getting all the communications get together to roll out, and we'll be calling emergency meetings of the leadership of seniors organizations, of the nonprofit sector that supports public health care, of unions and health professionals and others. We'll be meeting with the doctors. We'll be trying to pull together all of the urgent high-level meetings to try and pull the resources and attention to this issue that are needed. We're going to need the beginning of January to do that. In the meantime, everything that you could do, op-eds, letters to your MPP, letters to your MP, every bit of social media you could do will help. Okay, Carrie.
I have seen projects in the past where participants are encouraged to call the MP or the MPP with a plan on a certain day. And I'm wondering if that's something that could be perhaps focused on certain days, for instance, where we email or we call on certain days. And I'm hoping that something like that could maybe be arranged where we just kind of hound them in a way, especially those of us who live in primarily blue areas. I'm sorry, I'm hearing voices. And
I'm not hearing them. Is anyone else?
There's a bit of feedback, but
okay.
Yeah, but please go ahead.
Thank you. Campaigns like that we can do ourselves, something like that. I'm just kind of reaching here. On a fixed income, so I'm looking for ways that something that I could do, whether we call or email or.
It's a great idea. For sure, we'll do that. Thanks, Carrie.
Yeah, I'm in Simcoe County, so it's a blue area. And I'm not getting anywhere.
Well, but you're right. If they were hearing from dozens and dozens of their constituents, we would. So it's a great idea. We'll do, for sure. Heather.
Thank you.
Thank you. Go ahead, Heather Kelly.
Hi. Thank you, Natalie, for bringing this to everyone. I think, the more that we hear it, we can feel your passion. We know that you've been fighting for this for a very long time. Being in one of those small communities, having lost our overnight hours for our UCC, you can see.
That's an urgent care center. Sorry for people who don't know.
Yeah, trying to put a fight back. We find a lot of times that at least in our area, the doctors themselves are the ones that seem not to want to stand out and protect our public healthcare system, even though they're the ones that are benefiting. And that I think is very frustrating for the people in our community uh, because, every time that we send a letter to Sylvia Jones, oh, look at the big brand new shiny hospital that we're building you in Niagara Falls. It's good for people that can get there, not so good for people that can't get there. So, we really see the two-tier system at work and just the kind of information that's being put out there to make it sound like it's all wonderful that they're providing this service, quick
Yeah.
access to care. And we know that the care that is being provided in our public system right now, we have to wait, an extremely long time. So when your
Yeah.
doctor says, well, I can get you into Mississauga in the next month for your surgery, right? People are going for it and then coming back and they feel
Okay.
ashamed to participate any longer in trying to save our healthcare. So that seems to be one of the issues that I just wanted to highlight. We're doing the best that we can, but we need that larger support. And I understand you're setting up those meetings with the medical professions and certainly anything that you get out of that would be greatly appreciated. Thank you.
Okay, for sure. Yeah, no, Heather, it's terrible. Niagara, it's absolutely horrific what's happening in Niagara. Unbelievable. And we have to do everything we can to try and stop the closure of your hospital in Fort Erie and in Port Colborne, and obviously the dismantling essentially of the Welland Hospital as well. And then right now the deficit and the cuts that are happening right now as well. So really big problem. Also difficult in a community when the doctors are employees of the hospital for them to speak out. So we got to bring in retired physicians and physicians from other communities to talk about it. Okay, but thank you. I'll note that. Okay, I'm going to go to Genevieve, then Ken, then Carol, then Sam. I thought I saw Michelle Robideau's hand up, and I was hoping that she would speak if she wants to. Genevieve.
We have a question in the Zoom chat from Manisha Dar. How does cancer care and heart care fit into the privatization model?
Well, it does. I mean, it doesn't. I think what we're going to see, like all of this, is a redirection of resources away from all of the hospital budgets to the what are called elective surgeries, the high volume, easy surgeries that are considered profitable, right? So, I mean, that's where it fits in. The resources are taken away from everything else, and normally the result of that, because we have a public health system and they're not allowed to just sort of say that they're not going to provide this service. So what they do is try and manage with too little. And they end up doing things that are very costly, like centralizing more and more and more care, which costs a lot of money. Actually costs more to move it and shut things down and so on and so forth, as we've seen over the years. But there's been a whole class of managers that have made a living out of technocrats that have made a living out of bean counting and managing the cuts as they've come along and taking money away from services. So it just compounds on itself. I mean, we got to push. I have to say, we have to push in Ontario. We've got to push all the political parties. The Liberals need to be pushed. We need to hear from them that they're not going to actually move anything out to private clinics, that they're going to actually roll them back into public hospitals. And if they want to have ambulatory care facilities like day hospitals that just do a whole bunch of fast track cataract surgeries or what have you, fine. You can do that as long as local access to care is not threatened, because normally that's a centralization thing, and as long as it's under the governance of a public hospital and not a private for-profit clinic, or even a private so-called non-profit clinic that basically operates like a for-profit clinic, So that's what we need to do. We got to push the Liberals. We have to push the NDP to put this issue back on the agenda. Yes, the Skills Development Fund and corruption is a big issue, but so too is the destruction of our public health system and our public hospitals. And we gotta, push as hard as we can. And then obviously the Conservatives. Ken.
Thanks, Nadia and Natalie, for all your hard work again. You're tireless, and thank you very much for all of Ontario. I just want to say that on an emergency basis, my son in the last year and a half has had a heart attack and cancer,
Oh,
and the heart attack he went right away to the hospital of Sunnybrook and to an ambulance, and they treated him very well. They saved his life. And then by going back for his follow-up, they found out that he had throat cancer as well. And that treatment started right away, and he's well, really on the mend now. He had to get some teeth work done, and that had to be done because of the chemo. And so on that part, everything was fine, but that was on an emergency basis. Getting MRIs and getting doctors is terrible. And the privatization that's going on, there's no question. Doug Ford is Danielle Smith, but with a smile on his face. There's no question about that. I encourage everybody they've got 3 months off now, and I encourage everybody to go and speak to their MPPs. I'm going to do that on Friday. I got an appointment on Friday at noon, and they're not doing anything till the end of March. And like you said before, they need to hear from us and hear from you personally and your stories.
good idea, Ken. Perhaps in the chat, if people want to go and speak to their MPPs about this and want to go together in a group, or even get together and like do a letter writing session and stuff like that. And you're not already linked in with your local coalition, why don't you put where you are in the chat and that you want to link with other people. And let's see if people can kind of link up together through the chat. And then we'll also do our best to kind of connect people in after this meeting as well. Thanks, Ken. That's a great idea.
Just one quick
I'm
thing.
sorry about your sons too, and I'm glad he's on the mend.
Yes, he is on the mend, and thank you very much. But I'm in a conservative riding, totally blue. If you put a rock with a conservative sign on it, get elected up here in Simcoe. But the point is, they're the ones that you need to go and talk to, particularly. I mean, you're right about the Liberals. I think they will do the same thing anyway or do nothing. But we need to talk to those conservative MPPs and let them know. Thanks again for your hard work. Thank you.
Okay, thank you. And also, just to let you know, we've pushed every party, right? We won a promise from the Liberals prior to 2 elections ago to stop for-profit long-term care. Even that was when Stephen Del Duca was the leader. That was dropped, as I see in the last election. We got to push back for that. On the private clinics, I feel like we're partway there, but not totally there, and we need to push on that. We had to push them all, and we, things are never inevitable in politics and in advocacy. So let's do the best we can in those areas. Simcoe, all along Lake Huron, all of the countryside around, the whole north, all of the southern large cities, bring the messages that make sense to people about what this means in your community. And let's see what we can do. We'll see as the year progresses how things widen up for us as we do it. Thank you, Ken. Great idea. Carol. Go ahead and unmute, Carol.
Thank you. Sorry, I was confused by all the buttons that popped up.
No problem.
So you have given us a wealth of information, as you always do, and it's very much appreciated. Getting into the nitty-gritty of how the system, our health system works, though, is pretty overwhelming for most people. So my question is really about messaging. You promised that we would receive information that we could post. So I'm just trying to imagine me posting this on my socials and having people understand what the points I'm trying to get at, because there are 100 points, and we don't want to. I don't want to kill anyone with all the information, because it is a pretty Byzantine system when you start to get involved with it. And I just want to make sure that there's clear messaging available for me and others to use. So is that what you're going to be sending me?
Yeah, I feel the same. I set out to write a briefing about the Alberta legislation, and I realized that it's hard to explain the Alberta legislation if people don't know what we already have. I think this is how we have to deal with it. Education kind of goes in tiers for us. Like when we were fighting the P3 hospitals, some of you will remember the so-called public-private partnerships. We should have gone for simpler language and just called it privatization rather than going with their language, which was public-private partnerships. That was a mistake. But we had to sort of educate a tier of kind of activists and people who deeply care about the issue to know more. And then they went out and educated and so on and so forth. And the amount of information and the complexity of it sort of varied depending on, who you were giving it to and how much attention span they were going to dedicate to this. I think we have to do the same thing. So we have to produce the more complex things, the less complex things. At this point on Alberta, I only really have the one kind of complex briefing note. Across the country, the provincial territorial health coalitions got together. We wrote a letter to the premiers. It's much simpler and it's one page, lays out the threat. I think it's pretty good. It's a simpler, shorter message. Did we send that out yet, Sala?
No, but it's available on our website. I'll put a link.
We're going to send that out today, right? Right after this. We sent it to the media, but we didn't send it out to our listserv because we sent out so many things yesterday. So we'll send that out. All of the other stuff, we do actually have a lot of kind of shorter, pithy, clear messages about the privatization of the hospitals and the surgeries, the key arguments and so on. So yes, we've got it varied. We don't have as much of the short, simple stuff as we need. Obviously, the leaflets will have that. So we'll keep producing and we'll keep we'll keep working at it, So we'll produce things and then critique it and engage in a little bit of self-criticism and come out with better things and so on and so forth as we go. So short answer, yes, with also other more complex pieces for people and so on. But I hear you, and yes. And we're going to get them out as fast as we can. Like right now, I can't even tell you how much work we've done. It has been nonstop. So it's also just about time. So as fast as we can get them out. And that should not prevent anyone from producing your own based on, we're trying to give you enough stuff to produce your own, like I'd like to see videos of all of you. Say what matters to you, why you support public health care and why you oppose privatization, little missives and things like that. All of them help. Okay, Sam. Thank you, Carol.
Thank you.
Hi, I'm Sam Weiss. I'm the president of the British Columbia Federation of Retired Union Members. And I'm here obviously because I want to pick up the information that's being presented here so that we can continue our fight here in BC. One of the things that I would like to see in the information that's coming out, Natalie, is not recommendations. I guess you provide all this information. We have great networks that each one of us work with. But one of the things that I think we forget to do is consider that everything costs money. We fought Dr. Day and we won, but it was a cost. And so I'm just putting a plea out there to ask that from the Canadian Health Coalition, from the Ontario Health Coalition, that we remember that our fight is going to cost some money and that we get down and empty our pockets, so to speak.
Oh my gosh, Sam, thank you for saying that. It's the end of the year and I've been stressing because we had this kind of long postal issue and that has affected our donations and I'm worried about meeting budget targets and so on. Obviously we're going to build the biggest fight we can, and it is completely, we're limited by the resources we're able to raise. Like the money that people donate, every cent of it goes to this fight, and the same in British Columbia and the same in Alberta. The health coalitions across the country, I tell you, like there's no movement like us in Canada. Grassroots citizens movement like we have. to protect public Medicare. It's why the politicians are so afraid of going, in a head-on, full frontal fight against it, like Danielle Smith has been emboldened to do in Alberta, but they're not in the other provinces yet. And it's us that does that. So thank you, all of you who are members and who donate and support. And thank you, Sam, for raising that. It matters hugely. Judy. I know it takes, I'm going to say it's Judy, Michelle, and then Bailey. Sorry. I have this big black thing covering your face too, because it's just how the Zoom shows all of the admin stuff. So all I see is the name. Okay, Judy, are you having a problem? Why don't we let Michelle go, and then you keep trying while she's going. Go ahead, Michelle.
Yeah, I just want to, first of all, thank Natalie and the Ontario Health Coalition for this incredible, dogged work. Honestly, at the moment that we're in, I think all of us owe you a debt of gratitude. I just want to say that from the start. I think we have to have all eyes on the Ontario Health Coalition Activist Assembly, January 24th and 25th. I think that is going to help us solve a lot of the problems that people are raising about how can we reach out, how can we, what is the messaging, all of these things. And so just really encourage people, even come in by Zoom if you can't come in in person. But I think that should feel like full battle rattle for all of us. I really wholeheartedly agree that we are really in the SHIT right now. In terms of messaging, I feel like, we are in a situation, because I share what people are saying is like, what do we pull out of all of this torrent of problems that we're facing? And I think the pro-privatization forces are really working hand in hand to flood the zone. It's what, they do. They have been doing south of the border and overwhelm people. And I think what I've been thinking about is that I saw an article last week about the Ottawa Hospital and this private hip and knee surgery clinic that has been incubated inside the public system, using the unused surgical rooms on the weekends. And they have now, after incubating this private clinic, it's now going to be on its own. And I wonder if there's some way that we could take that example to explain to people. When you talked about, many years ago, Natalie, about the hollowing out of the hospitals, the process, they cannot dismantle public health care without completely gutting the hospitals. This is to me, like the premier example that I can understand in my own, very rudimentary way. So I wonder if there's something we could do with that and what you think about that. And the last thing is just on the online petition. We launched the online petition. We had trouble finding an MP in Ontario who we could come up with, who could, because it needs to be supported by them. And it ends on January 16th. So please, 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 everybody, if you're on a Labour Council, put it on your Labour Council newsletter, get 100 more signatures. Let's get it over 10,000 by January 16th at least. But I think we should have, is there another coalition like in BC or Alberta who could kick it off? Because our focus was, enforce the Canada Health Act in Ontario, because we're up against Ford, but for God's sakes, we should, and I think just this rolling thing that we can all sign, it's a different petition, we can just keep signing, but the problem was getting this in the midst of all the noise, getting it out there. So I don't want to be defensive about it and say it was a mistake. I think but we just keep it rolling because they're all slightly different. And the paper petition, we need to improve how we're using that to collect information from people about how we can reach out, because the model of the referendum campaign for us, in the Health Coalition, I think that should be our site should be set on something like that, an operation where every local coalition digs deep in their networks to pull people together. And I think that will be the real challenge for us to how can we replicate that in a different circumstance.
Totally. Yeah. So last year, and the year before, we reached 1 million people, more than 1 million people person to person with leaflets in Ontario. It was amazing. Of 15 million, right? 15 million population. Pretty amazing stuff. And we had this referendum where we got more than 400,000 people to vote against the privatization of the hospitals. It, without question, has like slowed things down. And the fact is they haven't really substantially been able to bring in the private clinics in the way that they tried to. You know, they have expanded, but they haven't expanded anywhere near to what they announced, what they have repeatedly announced, the dates and the targets and so on. That public pressure work is the key thing. So yeah, Michelle, we need to, like, I'll build more explicitly into the action plan, that stuff. For the petition, yeah, I sort of misspoke when I said mistake, because it isn't a mistake. It's just hard to get those online signatures, harder than I could have imagined. And I don't want it to be a show of weakness. So, like, please, we need people to help. I mean, there's no other way to do it, right? Please just bother to do it if that's okay. And maybe someone, Genevieve, or could put it in the chat again, the link again, just so people get it. It's like down towards the current part of the chat. On the sort of deluge of info, we will have an action plan. It'll be written out. It'll be clear town to town to town what we need to do. But we do actually need to get that assembly together and get people to come and sort of roll it out in your parts of the province. So I do agree that we can sort of sort out a lot of connecting people and so on. There, it's hybrid. It's online and in person. So you're welcome both ways, okay? And maybe we could roll petitions province to province to province or something like that as well. Okay, Judy now, and then Faylee.
Okay, just a quick question, because someone brought this up at our local meeting the other night. I'm from Grey Bruce Health Coalition. So is Jane Philpott, I know that she's been hired by Doug Ford government to, you know, help set up health teams and all that kind of stuff. But is she someone to be trusted, or is she kind of like a wolf in sheep's clothing? Like, I thought I heard you say one time she's not entirely against privatization, and they're pretty slow at getting that rolling out. If they're
okay. Yeah, I'm going to answer that super quickly. So Jane Philpott is the person that they brought in as the expert before the election. They did it as a PR thing to announce, because they knew that 2 million Ontarians didn't have access to family doctors, record-breaking numbers of people, and that was going to be a big problem for them in the election. So they made an announcement, and even though they didn't actually do anything before the election other than announce this kind of emergency expert panel, or what, I forgot how they packaged it, it gave them something to say when faced with the criticism. Jane Philpott, you know, my experience with her is that as federal health minister, we phoned every private clinic in the country, and we asked them, we posed as patients and we said, you know, can we buy whatever it was there, you know, like shoulder surgery or whatever, how much would it cost? Can we jump the queue, etc. We caught the majority of them jumping the queue. We did it in partnership with the Globe and Mail. And so the Globe and Mail took the transcripts we had of all the calls, sent them out to all the private clinics, got them to answer, got them to comment, and then published it all in a 5-part front page series featuring patients who'd been extra billed in private clinics, clinics that had engaged in double billing, billing the public system and billing privately for the same service, et cetera, and mounted enormous pressure on her as federal health minister to enforce the Canada Health Act. She said she would. Nothing special happened as a result of that. I was on TVO's The Agenda in a debate. They brought on a guy who was, they announced him as being from McMaster Hospital, but he was actually the owner of a private clinic as well, where they charge patients for access to a non-OIP covered procedure. And Jane, and it was kind of 2 against 1. She posed herself as kind of being in the middle between the extreme of him and me, as though single-tier public Medicare advocates were an extreme. It was ridiculous. She said that she didn't think the problem of extra billing was that big of a problem, and she purposefully conflated private doctors' practices with the privatization of surgical clinics. I thought it was very disingenuous. I was really annoyed at her for doing that. It was not right. She did not back us up, not at all. In fact, when the Ford government brought her in, I was very worried, but she's done some really good things. She has, for example, vastly expanded the community health center in Kingston. And that's a nonprofit public model. She's been pushing sort of nonprofit public models of primary care reform, team-based approaches, things like that as well. All those things are good. When she sort of acts as though she's agnostic on private for profit, obviously that's not agnostic, right? Because the thing is we have to fight privatization now, or they're going to take over. So it's a bit of a mixed bag. And I see Ross Sutherland, our chair, is on here, and he and I have been talking a lot about the primary care reform. He's been tracking what's happening in primary care. That's the front door of medicine, access to doctors, family health teams, community health centers, nurse practitioner-led clinics, the other types of teams, and so on. And we are going to come out with a report and so on measuring what's actually happening there. There are some good things, without question. Sorry, that was supposed to be short.
Can I say one more thing too?
Yeah, quickly though, because we're kind of off topic here.
I was watching a committee meeting that was on home care, like it was public consultation or something.
Yeah.
And the conservative members on the committee she said it about 3 times. Well, Dr. Jane Philpott says the word privatization has been weaponized because they had consulted with her even before this consult.
Yeah.
So anyways, she said that.
I met with her, I should tell you also, during the pandemic about what the possibilities might be to win national standards for long-term care when all those people, like thousands upon thousands of people were dying, the vast majority of them in the for-profit chain companies that were taking their dividends while not staffing and providing the care. And she was terrible. She was terrible. She was trying to dissuade our forces from pushing the federal government to demand that a national standard be that federal funds go to nonprofit and public long-term care only. I was shocked and horrified. Yeah.
Okay, thank you.
Thank you. Okay, now, Faili, am I completely massacring your name? I know it,
okay.
actually. I'm sorry.
So my name is Sally Clark. So I'm from Owen Sound. So we are a small community. So in my personal experience, when my husband needed heart surgery, we ended up going to London. I'm so glad that we have a public healthcare because being said that, me being his primary caregiver, I have to live in a place, in a hotel. So can you just imagine if I still have to pay on top of that, the hospital bills, I would not be able to afford. I may not be able to even take my husband for heart surgery. So I think our public healthcare system, our universal public healthcare system is so pertinent and so important as a Canadian people, And what can I do for the Ontario Healthcare? I am part of the Grey Bruce Healthcare here, coalition. So when there is a flyer, and for all those other people that would like to help, I take the flyers and I put them in the mailbox, okay? And those people that would open the door for me, I always tell them the importance of our public health care. And I really hope that everybody would do the same. We really need our public health care. You think life is hard now? When you reach the part that you got sick and you need that public health care, and then we ended up having a private health care. You know what? You're going to choose. Should I take my loved one for treatment or should I feed my family? Sometimes it's as simple as that.
Yeah.
Boy,
Yeah.
it's so heartbreaking. And
Okay.
thank you, Natalie, for all your hard work.
Ellie, thank you. And I do believe we've met before and I've heard your name, right? I'm
Yes.
sorry for doing that to you.
That's okay.
Okay, I apologize.
Thank you. Thank you.
Manisha, you got to be quick, okay? I just want to sum up in 2 sentences sorry to rush you, but we're way over time now. So I'm going to sum up after you in just a couple sentences. Feli, listen, our best wishes to your husband, okay? And thank you for working with the Grey Bruce Health Coalition. They're so amazing. Yay. I think we're talking about doing one of the 1,000 person rallies somewhere in Grey Bruce. It really matters. So we'll have to consult with all of you about that. Manisha.
Hi, I just wanted to encourage people to please get contact information when they get people to sign a petition or when they have contact with people. It can be helpful later on if you want to do some phone banking or if you can set up like phone trees and all that kind of stuff. So that was it. But really
No. Okay, that's perfect. Thank you. Really important. I believe that the paper petitions, Sally, correct me if I'm wrong, they all have a check mark so we don't add people to lists without their permission, just as an ethical thing. But I believe they all have a check mark column, right, for people to be added.
And an email column, and they need to add a check mark with the email to indicate they want to be kept.
And it says it there, right?
It says it, yeah.
Usually we have a box. Maybe we need to fix that and make it clearer if people aren't realizing that. Thank you very much, Manisha. Absolutely, that's critical. The online petition, of course, goes to the House of Commons. We don't have access to the people who signed that. We're asking people to sign both. I know it's odd, but they're slightly different. They'll be counted separately. They won't count together. Okay, just want to end with this. You know, some of you have heard this story before, but it's Alberta, and so I have to remind us that once a long time ago, Ralph Klein, who was this terrible political leader in Alberta, they imploded the Calgary hospital, as I recall. They brought in a bill to privatize hospitals. They were terrible. And the fight back actually stopped them in Alberta. Just so you know, it can be done. And they did it repeatedly. This is the Friends of Medicare, our sister organization in Alberta, and they're ramping up. They've been doing tours across the province now. And Ralph Klein, the premier, famously called public health care the third rail of Canadian politics. And he said that, politicians dare not touch the third rail. That's the electrified third rail. The train goes down the tracks and then there's the third rail and it carries the electricity. And I always loved that. I was like, yes, Ralph, you be afraid of the electric third rail, and that's us. Our job now is to electrify the third rail. Let's make them pay a price for coming after our public health care and trying to take it away from us. They have no mandate to do it. Canadians do not want this. It is not time to be quiet and meek. It is time to raise our voices, as Tommy Douglas said, in no uncertain way, and insist that we protect our public health care or we're going to lose it. Thank you so much for joining. We'll do another with a less huge amount of information, more on the action plan in January, and then we'll do the assembly. And just to remind people in the meantime, please sign those petitions. If you are able to donate and you don't already, we appreciate it. Same for the other provincial and territorial health coalitions. And what was the other thing we were doing? Petitions. Come to the assembly. Contact your local MPP and MP, right? And we'll send out some more stuff as the week progresses so that you can get out the messages on social media. Okay, thank you all so very much. Sorry, a little overtired and emotional today. I appreciate your patience. Bye-bye, everyone. Thank you.